So I've organized this talk. It should take about 18 minutes in three sections. The first one is why resilience and where did it come from? The second section is about human suffering and the real. And the third, the final section is what is the legacy of COVID for healthcare services and for nurses? During the 1990s, the concept of resilience came to prominence in many areas of public policy and systems thinking, whether ecological or military systems or urban planning. It was about building in ways that would allow these systems to recover from disaster. But also notable and not unlinked has been the rise of resilience as a psychological property, and that's the focus of this book and my interest in the term. Its origins as a psychological construct are found in child psychology from the 1980s, a concept invented in order to explore and explain why some children appeared to survive adverse upbringings while others appeared to succumb. These researchers, child psychologists, generally understood any particular child within the context of its family, neighborhood, and school, and explored resilience as an effect of combined But I think resilience, or rather the way it came to be promoted, or talk of resilience, you could say, quickly became part of, or was seen from the perspective of, the positive psychology movement. Just as the positive psychology movement has its focus on subjective individual experience of well-being and ignores material conditions, so resilience came to be understood as an individual psychological trait, and some argued that it could be encouraged or strengthened by particular activities. And these activities were intended to fashion some kind of change in thinking or attitude within the individual. The mantra has been, you can't always change your situation, but you can change how you respond to it. From the point of view of positive psychology and the promoters of resilience, the action needs to take place inside the heads of individuals. The promoters of resilience have, as I said before, tended to ignore material conditions. I came across this quote from Ian Parker, who's a radical psychologist and a Lacanian psychoanalyst. More about Lacan later. His book. And Ian Parker writes, unbearable misery is treated by psychology as if it were a disorder, failure, or illness. Our own oppression is then turned by psychologists into negative thinking. This approach has an obvious attraction for managers and some politicians. If individuals can be convinced that it's their responsibility to provide a solution to system inequalities and dysfunctions, then efforts to make material changes to address these situations might be avoided. A hard-pressed manager can tick off a number of to-do boxes by setting up gratefulness sessions for her staff, rather than grappling with those factors that gave rise to the need for resilience in the first place. And at this point, it's worth making the crucial point that you could say that nurses face two different kinds of adversity, if that's the right word. One is intrinsic to the work, but the other is an effect of working conditions that are in turn a result of policy and ideological decisions made by particular actors. Also, as an aside that I only mention here, but develop more in the book, we can make the argument that the detection or discovery and measurement of an apparent thing labeled resilience is an example of reification. Resilience was there all along, and now we have discovered it and are able to measure it and maybe even manipulate it. But we could alternatively see resilience and those apparently correlated properties as the effects of the questions or instruments devised and used by the psychologists. It's brought into existence by them. And the label itself is not innocent and points to myth, drama, religious sentiment, deeply embedded stories of human triumph over adversity that allow resilience to reverberate with significance whenever it's mentioned. And early researchers did speak about invulnerable children before settling on the term resilience, as in this collection from 1987. Right, part 2, human suffering and the real. In one chapter of the book, I introduce various theories of trauma. You might say competing theories and understandings of trauma. On the one hand, those emerging from what you might consider mainstream psychiatry, and on the other, certain psychoanalytic models. And of course, the word trauma is used more colloquially to refer to any distressing experience. It's my argument that in nursing, trauma is never very far away. As long as there have been wars, there's been interest in the traumatic effects of war on combatants. The First World War, and then later the Vietnam War, marked two key moments in theorizing about what we have come to know as trauma. The first use of the term traumatic neuroses is in 1884 and the title of a collection of case studies of industrial accidents written by a German psychiatrist, I think. Soon after this date, Sigmund Freud and Pierre Janet, working in Paris at the time, developed their idea of traumatic hysteria. The key feature of Freud's theory of trauma was that the sufferer's memory of the traumatic event remains separate and unintegrated into that person's conscious narrative memory, but can be activated by a subsequent event that the person links unconsciously to the earlier event that was ununderstood at the time. And it's Freud's well-known talking cure and free association that he believed can enable his patients to begin to come to a conscious awareness of that earlier event and its meaning for them. John Huston's 1962 film, Freud, the Secret Passion, shows us a version of that talking cure. This retroactive nature of trauma accounts for why two individuals experiencing apparently the same event may respond very differently. And now I talk about the DSM, the Diagnostic and Statistical Manual of Mental Illnesses. And that was and still is the American Psychiatric Association's categorizing handbook of mental disorders. Its first edition was published in 1952, at a time when psychoanalytical concepts dominated thinking about mental disorder. But over its subsequent editions, culminating perhaps in the DSM-3, published in 1980, this psychoanalytic influence was expunged by groups within the profession who wanted to replace the apparent speculative nature of psychoanalytic thinking with more empirical bases for mental disorders. And they wanted to do this for a number of reasons. Post-traumatic stress disorder, PTSD, emerged from this context, diagnosed and defined by the severity of the event causing the trauma. And they define it, an event generally outside the range of usual human experience, of which they give many examples. So those promoting this event-based diagnosis wanted to make it easier for clinicians to justify the diagnosis, and also perhaps to avoid straying into questions of whether the sufferer was a malingerer. This approach, though, leaves us with the problem of accounting for different responses to the same event. And it's interesting to think about this in relation to nurses working through COVID. So returning to nurses and to psychoanalytic theory, another puzzle or discussion point arises from the proposal of trauma as a gap in conscious memory, as something that can't be symbolized, usually in words, can't be spoken about by the traumatized person. That's broadly Freud's understanding of trauma. But we can't fail to observe that many nurses have been very vocal and specific about their experiences during the pandemic. And while I was writing this book, I spent a lot of time reading the RCN's ICON study and their various reports. There doesn't appear to be a failure to symbolize here, quite the contrary. But I suggest that how to approach this is a matter of purpose. So when it comes to working with any individual nurse who suffers the effects of trauma, it could be important to explore in depth what the events of her work during COVID meant for her in the light of previous life history and unconscious memories. It's possible to wonder whether, within the vivid testimonies that we have all probably read, there is something that is not spoken by each nurse, something that might be the key for the trauma experienced by that individual. Arthur Frank's ideas about different types of narrative that people tell, including a chaos narrative, are useful here. Frank notes that he first became aware of the idea of the chaos narrative when listening to Holocaust stories and commentaries on them. And he writes, "What cannot be evaded in stories told by Holocaust witnesses is the hole in the narrative that cannot be filled in, or to use Lacan's metaphor, Jacques Lacan is a French psychoanalyst, to use Lacan's metaphor, cannot be sutured. The story traces the edges of a wound that can only be told around." End of quote. This horror, the real, remains unsymbolized, untold. Perhaps the testimonies by many nurses involved in the ICON study, like the health visitor who spoke to researchers about seething with an anger, but not knowing who the anger was aimed at, can be seen as a kind of tracing around something more awful and as yet unspeakable, a total loss of control and a sense of falling into an abyss of chaos and suffering. So the last section, what is the legacy of COVID for healthcare services and for nurses? There have been plenty of statements about the future employer and workplace values, more concern for worker experience, flexibility, etc., more influential roles for nurses, both from the NHS in the UK and from the ICN, for example, that they've turned out to be unrealistic, I think. The overriding force seems to be that public services, at least in the UK and possibly other countries, have been run down to such a point that failings are now deeply embedded, and these calls are just unrealistic, at least at present. But there is some hope. The end of resilience of the book's title signals that in the policy arena, the individualized version of resilience has had its day, or at least is being questioned. Where policy actors, for example, the UK Parliament select committees, where they're concerned with understanding the NHS climate and how its problems can be addressed, you can see, if you read the reports, you can see witness after witness to this committee urging its members to focus on questions of system resilience and function, and not be drawn into a focus on this notion of individual resilience that does not help in understanding how to improve systems. Right, to conclude, Like everyone here, I yearn for better days, but I know and experience it in glimmers that in the midst of what feels like danger and chaos, I found the seeds of a better future. While writing Nursing COVID and the End of Resilience, I discovered Cassie Thornton's book, The Hologram, Feminist Peer-to-Peer Health for a Post-Pandemic Future, published in 2020. And I ended my book with a quote from her, and I'll end this talk with the same quote. And she writes, "The real treasure is in the beginning that is before the beginning." Great, thank you.
Thank you, Michael. Very interesting, and we'll take questions at the end, if that's okay with anyone, with everyone. I'd just like now to introduce Georgina Morley, who's a clinical ethicist from the Cleveland Clinic in the USA. Georgina's had a copy of the book and has agreed to respond with some initial highlights of the book and observations, and hopefully that will help provoke some further questions afterwards. So Georgina, it's over to you.
Thank you very much.